Good evening, everyone, and welcome back to our series. We are delighted that you're joining us again, whether live or recorded, and that's the beautiful part of technology today, is that we can do these things live and recorded. As you can see, I'm not in my house. I'm actually at the Rodale Farm. I'm on the board of directors of the Rodale Institute, which is a leader in organic agriculture. And so I'm here on the beautiful farm in Pennsylvania. And delighted again once to be joined by Karol and Deepa and Sumit from ProNex. And as we have said throughout, our desire as an organization is to come alongside of you as healthcare practitioners with the tools and resources that you need to be able to deliver the passion that you have, along with the tools of lifestyle medicine and plant-based nutrition, to prevent, suspend, and reverse disease. And just as a point of inspiration, I was just here at the dinner tonight, and years ago, gosh, this must be 7 years ago, when I started working with Rodale Institute, I met an employee that was here, and she had multiple sclerosis with lesions and just really struggling as a mom. And I worked with her, and I just saw her tonight. I haven't seen her in a number of years. And she told me, she said, "You don't understand how transformational that was." She said, "I'm lesion and symptom free since that time you worked with me 7 years ago, and it changed my life." And so, what we want to do is provide a foundation for you all as healthcare practitioners where you can deliver this kind of care inside of your practice with the tools and resources that allow patients to adopt that lifestyle and allows you to get paid doing that. That's what creates the beautiful closed loop system. And so that's why we're here this evening with our dear friends from ProNex. And I'm going to turn it over to you, Karol.
Awesome. Thank you so much, Dr. Stoll. It's exciting to be back here again. It's hard to believe that we are already into session 4. It's going by so fast, and we have a wonderful guest tonight. I know that you're going to thoroughly enjoy. We've gone through from vision to viability, how to design your program, a bit about marketing, and then hopefully all of you received in your email this week a little additional marketing information from Deepa and I that included a written resource as well as a video to go along with it. And then tonight we are diving into the profitability and revenue streams and really how to scale practices. And so that's why we have the expert here with us, Sumit. I'll let him tell you all about him, but he's going to be a wonderful information here. He's going to be a great person to guide you through that. And we may as well hand it right over to him so he can get started.
Awesome. Thank you, Karol, for that.
Yeah.
And thank you to everyone joining and listening in. And hopefully I'll be able to share some information that's helpful to you and your practices and how you deliver care. So really just want to start with a little bit of my background to help just build credibility and where I come from. I have been a believer of lifestyle health and whole person care for a very, very long time. In my background, running RCM companies, clinical companies, and AI companies, I've always come back to that notion of how can we fill in the gaps between visits and how can we make sure to treat patients a little better. And many of the programs that I talk about today, I've helped my own family members get on them. I've gotten on some of them where available, but my background, I helped build the RCM side of things for Geneva Healthcare, which is an implantable cardiac device monitoring company, which they had an 8x exit and actually resold to Philips a couple years ago for a little over $2 billion. I was the customer success and analytics first person at Nudge Health, which was an early whole person care platform and lifestyle health innovator. I'm also invested in Nudge Health. I believe in it through and through. Built and sold an RCM company. I sold it to Athelis, which was an RPM company at the time. They've expanded in the RCM into a lot of various care pathways and technology platforms to support providers. And now currently I stand as the founder and CEO of Abstract Health. We're a hybrid technology and RCM firm. So everything I do, everything I talk about is trying to find ways to get providers paid for the services that they deliver to patients. And many times as I dig in with providers, I find that they're already delivering this type of care. They're doing all this work because it's just out of the goodness of their hearts, and they want to care for their patients. And a lot of times they don't realize that they can get compensated for this. So we'll talk about a few programs today that can help through that. And if you have any questions, please share them in the chats, and I will keep the chat open and try to answer them as quickly as possible. Cool. So I know we've had the patient throughout the whole group. The patient has been Maya, and the doctor has been Dr. Marcus. I'm going to keep with that program, and think about, like, Maya as a patient can be seeing a variety of providers, going into a variety of facilities, but really Maya can tend to get lost between visits, because in, like, the historical programs, fee for service has been akin to going to a body shop, right? You know your problem, you go in, you get treated for that problem. They may find another problem, try to fix it. But what happens between those visits, and how are you thought of, and how are you cared for? How do people think of those various tenets of lifestyle health? How do they think about your anxiety, your depression, your diet, your exercise? All these things contribute to how your conditions are affected, and all these things have billable codes for them. So while Dr. Marcus may be talking to Maya and helping Maya change her diet to get better, Dr. Marcus might not be getting paid. Maya may not be understanding that there are other programs out there to help her. So we'll talk through a few of those programs through the day, but I think the main levers are delivery and revenue capture, right?
So,
So
Sumit, I just
yes,
I just want to rectify just one thing. Maya is a character who is a non she's a healthcare professional,
oh,
but
I
not
apologize.
physician instead of a
I
patient.
apologize. I thought it was the patient of the doctor, so I'm sorry
No
for
worries.
that.
So we have two different kind of providers. You know, one is a physician and one is non physician. But Maya can be patient too. I mean, Maya is at the end of the day is a human being. So she can be have a role as a patient. But I just wanted to uh, clarify that for our
No, thank
audience.
you. I'll shift a little bit of the conversation to meet that, because I think that also helps, because in many times there are care providers that are not the physicians, like the dietitian, the physical therapist, the behavioral health providers. So we can, I'll shift it slightly as we talk, but so as we jump into the various levers, there's, when you think about this in your practice, or in the business you own, whether it's a facility, an FQHC, just a provider practice, a digital care company, a virtual care company, a technology company, really the question that you need to start with is, who do you serve? Because and how do you serve them? Because you can serve a multitude of patients who have similar conditions and similar problems, and you can deliver care in a group or a team setting, which is called a shared medical appointment, which can help you stack some of your revenue, help you help the patients also gain a community. And it changes, though, how your revenue looks, how you have to document it, how you can get compensated. So we'll go through a little bit. What does the one-on-one versus group actually require? And think about who on the team can deliver this. Because if you are provider led, this is where we get into Dr. Marcus now shifting from Maya being the patient. Dr. Marcus has Maya as a care provider on his staff, and Maya can deliver this care and just under the supervision of Dr. Marcus. And this also helps Maya gain experience. Maya help the patient gets different needs, and how do we move those patients through the model? So as we jump into the next slides, we'll talk through which programs can fit the population, what does it pay, because I think it's important for us to talk through that. What documentation is needed? How can you stack it? And what technologies can you use? What systems are going to track what's needed to meet the documentation requirements from CMS and other insurance carriers? So let's take a step back and talk through why these programs were created. And CMS has had this long shift from starting with fee for service and trying to switch to the value-based longitudinal care. And it started with CCM and RPM. Then what's not on here before what is now called COCM, it was called behavioral health integration. So what they were trying to do is bring a behavioral health aspect into specialty care and primary care. Like if you had a cardiac event, behavioral health, your behavior is a very, very important aspect, bringing that into the cardiologist's office and combining that care. So it's shifting from just your single specialist to a team to support you. And that's really where collaborative care came in. And then it shifted to, while CCM was first, CMS realized that patients also have singular chronic conditions instead of CCM is for multiple chronic conditions. And then PCM came out, which was a single condition. And more recently, what's come out is APCM, which is Advanced Primary Care Management, and the Advanced Primary Care Management Behavioral Health add-on. So they're just trying to expand having that single, your primary care provider managing all of this instead of you going to either a specialist to manage it or a third-party company to manage it, bring it back into your primary care setting. And these COVID helped because technology needed. Funding helped because a lot of venture capital and PE firms realized that healthcare is a new frontier. So we've seen a bunch of investments. So the tech-enabled remote and team-based companies have really blown up, and so many new ones have come. I think last time I did research using a product called Elion, on just the revenue side of things, there were like 700 point solutions. And if you think about that across all the care continuums, it's just, there's so many different technologies at play that can help both the provider and the patient deliver that care at scale that previously the EHRs or previously the PM systems couldn't. And that's also where ProNex can help deliver some of that, right? Because it's a technology enabled program. So we talked about these programs, and now talking about what does Medicare look like for this? These are just from a nationwide fee schedule. These are actually based on 2025, not 2026. Apologies, that was a typo. But these are per patient per month reimbursements that you can average. It does change by geography, by payer mix, but these are just by Medicare. And as you build out some of these programs, or as you do some of the homework we're going to give you today in understanding what these programs are and what they can do, I think you're going to come with a lot of questions, and hopefully some of the stuff we go through will answer them. But I wanted to flash this on the video for a couple seconds because I think it's very important to read through what these acronyms mean and what you can earn on a per patient basis. And these are add-ons to some of your in-person visits. Your E&M codes are separate. So you are probably providing these services already. And if your patient panel is even 10 patients, that's an extra $1,000 a month at minimum for the practice for care you're already providing. Now stack that up as your practice grows and grows and grows, that's a significant amount of revenue that helps keep the lights on, helps you deliver better care for your patients.
Sumit, can this be applied to the traditional insurance companies, or this we are strictly talking about Medicare?
So Not every insurance company. Many insurance companies do pay for CCM and RPM. The insurance companies are following suit in COCM, and PCM and APCM, sorry, and APCM. It will depend on your region, your geography.
Sure.
But I'd like to say I've seen in my customer base that go through these programs, we're at about a 60% insurance mix of patients that are eligible. Always, always, always do a check of your contract with the insurance carrier, because many times, since these are new care codes, your contract may not have them included. So before you deliver this additional care, review your contracts and also review your patient's policies, their patient plans as you run an eligibility check. The eligibility check you should have an add-on of a verification of benefits for the various codes that you're going to deliver. Let's say if you're delivering RPM, there's about 6 codes. So add a verification of benefits prior to turning this on, because there are so many plans these days that you may be, for using United Healthcare as an example, you may be credentialed with United Healthcare. You might not be credentialed with one specific United Healthcare self-funded plan. And that could be the outlier. So you have to think about that, and you have to run these checks as you confirm whether to deliver. There are many things you should do prior to delivering any of these programs. And I think, of course, patient eligibility, patients that need it. I'm not clinical, so I can't give any advice there on what patients you should give it to. But on the financial side, your contracts, and your patient plans, their specific plan, is it covered or not?
Okay.
Some plans will require a prior auth as well for these services.
Thank you.
So there's no right path. I want to start there. There's a lot of programs. There are a lot of different ways to do it. And I think if you are a primary care provider, APCM is a very easy layer to start with. And then expand that layer from APCM into some group sessions for patients with like-minded conditions, and have Maya handle those. Have someone on your team handle those, because in many situations, those group sessions can be handled. The language in CMS is a healthcare professional. There is no minimum requirement on their credentialing, but they must be a healthcare professional. I think that's a good way to start. And a lot of it is testing what works for your patient population and what works for you. But slowly add these on. Don't jump into everything at once unless you've done the research and you're already providing everything, which in all likelihood is unlikely. Do this slowly and build that revenue. But test. There are insurance carriers that will change. There is a lot reviewing the contract. But when you go down this path, if you start with APCM, for example, and if you're going to review and update your contracts, add in all the codes. That doesn't mean you can't that's a one-time exercise, and then start layering in and building your programs. So, which patients qualify? Now, CCM is simple. They have to have 2 chronic conditions, 2 or more. And those chronic conditions have to last at least 12 or more months. The patients are at risk of decline, and you need to build a care plan to manage those conditions. That care plan can be modified. That care plan can be edited within those 12 months. It's not like, hey, you start this program and that care plan is set in stone. There are codes that help you manage and change the care plan. There are codes that are dependent on the types of risk for the patient. There's less risky and more risky depending on their conditions. And then if you're not sure if the patient is, these conditions are expected to last 12 months, or if the patient has only one complex condition, there is primary care management, which is that one complex condition. And an overlay to that is RPM. If those complex conditions are cardiac related or weight related or glucose related, as long as you're providing them an FDA approved device and you are meeting the 16 days of transmissions, you can layer on RPM because you need to track their, if it's a cardiac event, you need to track their blood pressure. You need to track their transmissions. If it's sugar, you need to put either they're using a glucose machine or they're wearing one of those the continuous glucose monitors. There's special codes that we didn't even list here for just a continuous glucose monitor. And then for primary care management, which if you're a primary care provider, this is the easiest way in because you provide this anyway. It's any one of your primary care patients. And the codes are tiered by how complex the care is, how complex the patient is. These are very easy ways to qualify the patients.
Hey, Sumit.
Yeah.
I have a question, or rather a comment. See, when we are starting out, let's say somebody is very new, or they are already working in a system and now bringing the lifestyle medicine to their patient population. It all sounds very, oh my God, where should I start? Even though you said, start at the lowest tier. Can you give us one more tip about even somebody starts at that step one level, and build the financial model, how it grows, like from 5 patient to 10 patient, the ripple effect of starting is still worth it at the launching point.
Yeah. So I'll actually use these two programs as a good way to answer that and tie it into this slide. So what I recommend as you're trying to figure out which program and how to start, if you have a billing company, use them to help you with what I'm going to mention next. If you don't, you have your EHR, you have documentation of how you're treating patients, but look at pull a set of data for your patient population, look at their insurance carrier, and look at their diagnosis codes that you have already written down. Whether I've talked to people who are doing this just using Excel. I've talked to people who have PM systems and EHRs. But no matter what, the provider, you know your patients, you know the conditions you're treating. And tying it to this, right? Look at their types of conditions. Are they complex, not complex? Are they chronic, not chronic? And you have a starting point to understand how big this could be. To build the financial model, there's a lot of tools on the web. Like you can go directly to CMS's PFS, which is the provider fee schedule tool. It's online. You once you go there, it's a code lookup. These codes are listed in the slides you'll get. You can put in your zip code. You can put in these codes, and these codes will tell you what the reimbursement looks like, right then and there, and it's on a per month basis. And you can scale that out very quickly on understand. Like, let's say you've identified 10 patients. So just doing a multiplication by 10, you can do that via Excel. If you're just putting these codes, a lot of people I know will use GPT or Claude and just put in, hey, I have 99424. This is my zip code. These are how many patients I have. Can you build me a financial model? And that simple prompt will make it easy to understand. Now, expanding to other patients and other programs is also, a lot of it is word of mouth. Some of it is marketing. I'm not a marketing person in any way, shape, or form, so I don't have any advice on how best to do that. but I've seen it a lot of different ways that providers grow their panel for this treatment and these programs because other patients aren't getting it, and patients talk their friends. They talk to their friends. Hey, I'm doing this new thing. It's helping. It's wonderful. And my provider doesn't do it. Okay, let me come to you. Let me come to your provider. I've seen that work a lot. But also, in all honesty, many people within their panel, if you are treating Medicare age patients, there is a significantly high percentage of these patients that can benefit from one or all of these programs. And that's why, as I think it's about 4 slides from now, we have the stacking matrix. That's why CMS allows you to stack these programs, because most patients can benefit. They want you to get paid for this. They want you to provide this care.
Correct. Thank you.
Mm-hmm. So I'll deep dive a little bit onto, we tied that to the CCM and the PCM, and then remote patient monitoring has become the easiest path in for many groups, many systems. A lot of times you send your patient home, and I'll use one of my own family members. She went into the hospital. She had a cardiac, she thought was having a cardiac event, turned out to be a panic attack. And the doctor sent her home with, hey, go buy a blood pressure cuff. And I want you to take your blood pressure twice a day. And I want you to write it down on a piece of paper. And you're going to come back to me 30 days from now. And you're going to show me that piece of paper. And we are going to figure out if this was a true cardiac event or what triggers you. Because, like, if your blood pressure is higher or lower, write down, hey, what happened that morning? Was it something you ate? Was it someone you spoke to? Was it something you read? Just write it down. And when this happened, I laughed, and I was helping the family member write it down. I was going over some days, and I just couldn't help but laughing. Like, your doctor really wants you to write this down and come a month from now, and and I made the joke. So what happens if your blood pressure is so high that you're having a heart attack, or you think you're struggling, or what happens if you fall? And she was like, I have to write it down. And I'll tell my doctor in 30 days when I see my doctor. And that to me was such a shock. Like, that's how care is delivered. And seeing RPM, it goes directly to the provider. The providers you read your same exact condition. The patient would be sent home with the blood pressure cuff that's connected to whatever system the provider is using, whether it's their own EHR, whether it's a third-party platform. It'll be connected in. The provider can set their thresholds, whether, hey, this is what I consider high for this patient, this is what I consider low. They can generically do it with the levels of hypertension. But then the provider is getting that information immediately. It's automatically transmitting. And now the provider throughout the month is required to spend at least 20 minutes of clinical time reviewing those readings, whether it's blood pressure, weight, sugar, what have you. It just has to be from an FDA approved device. And so historically, when the provider would send you home with a piece of paper, the provider in the office would have to sit there, read the piece of paper, and figure it out. That would take them 20 minutes of time anyway. They weren't really getting paid for it. So now the patient's doing the transmissions. As long as you have a way to receive those transmissions and you spend 20 minutes of time at minimum reviewing them, you get compensated for it. But this is care that you should be delivering anyway. There's a variety of codes that tie to it. The minimum rules from a device, it has to be an FDA approved device. The Apple Watch or the Garmin watch or the Samsung, none of those apply for blood pressure or sugar for the time being. I'm sure one day it'll all be built into our smart devices, but for now, it has to be tied to a device that the provider gives you, because also for that, the device that's given, whether the patient pays for it or the provider has to help you understand how to set it up and use it. and the provider gets compensated for that. And the provider can use any healthcare professional, doesn't have to be the doctor. Even the front desk in their office is considered a healthcare professional that shows you how to use that device, and you get compensated. This is stuff you would do. Again, this is stuff you would do anyway. Why not get paid for it? Let's jump into the newest program. And I think this program, in my opinion, is brilliant. This is the future of primary care. This is what should have been, probably was being done in primary care in the past, but providers weren't paid for it. Trying to fill in those gaps between visits for the PCPs. There's no monthly time commitment. There's some service elements required, but depending on the patient's conditions, you can get an extra $15 to $120 a month to look at patients and to look at their conditions and to treat them. Also, if a patient is QMB, which for those that don't know, QMB is a qualified Medicare beneficiary, you cannot bill that patient a penny. The patients have zero patient responsibility. So Medicare has decided to cover them in this situation. It is the first program that QMB patients are covered and get paid instead of just writing off that difference where you cannot bill them. This is the greatest new program I think CMS has come out with to help primary care providers. And they're adding on codes that are reimbursable that's coming, like your health and wellness coaching, your dietitians, those new codes. Some of them have gotten approved, but there's no reimbursement rate yet. I think for wellness coaching, for example, that became an approved code about 2 years ago. They're finalizing the rate. We're hoping to see one in the Medicare final rule that comes out in a few months. How can you stack these? So I'm going to keep this on the screen for a moment before we move to the next slide, because I think it'll be important also for the recording. All these green checks. So if we're looking at this top program, I'm just going to draw, excuse the terrible lines that you'll see in a moment because I'm terrible at drawing. But if you see the left RPM, it can be stacked with every single other program. That's the way this looks. The gray means that's the program we're talking about. Green means it can be stacked accordingly, and the X's mean you cannot stack that program. Now, this is huge because if you're providing all of these services for your patients, now you still get your in-person visits or your virtual care visits that you get paid for because you're treating the patient, you're doing your one-on-one time. All these others, if they're added on, you can make up to $400 plus per month per patient. That's a lot of revenue for care you provide. There are requirements that you cannot double count time. So if you are, and this will be part of what a shared medical appointment can complete as well. But if you're doing if you're reviewing their conditions and you're trying to tie it for RPM and COCM time, that's where you'll get dinged. And that's where you're quote unquote committing fraud in Medicare's mind. So be very, very careful how you document time and how you write that time down. Like I am spending 10 minutes reviewing RPM readings. I'm spending 20 minutes reviewing care for my collaborative care program. I'm spending 10 minutes on these chronic conditions. Just make sure it's very, very, very clearly documented and make sure you get consent. So the patients need to sign a consent to join one of these programs. And if you're providing collaborative care management, which eventually will be branched out, and I'm sure they'll call it lifestyle health in CMS, but that's those where you're treating any tenant of lifestyle health using a behavioral health provider as well. If you're doing like a diet class, like a nutrition class, or you're doing an exercise class, you can use a healthcare professional and you can have many patients on the same visit. And you can use that to stack your revenue and treat 20 to 30 to 40 patients at a given time. There are minor requirements like breakout rooms. You give the patient some one-on-one time, but overall, you can then, that 400 a month, if you have 20 patients and you're doing it using your shared medical appointments, 400 times 20. And you're doing that by spending one set of time as opposed to 20 sets of time. That's where these group sessions and these shared medical appointments are very, very significant from a revenue standpoint, but also taking it back to what a patient looks like using that family member. She used to go to a joint it was like a chair yoga class that was she would be able to airplay it to her TV, but she gained a community from that. So it also helps your patients gain a community of like-minded people. How does billing look? And we've talked around the edges of this throughout this session, but consent, consent, consent. If you do not have consent first and you are not documenting cleanly, nothing else works. It breaks the entire rest of the cycle. If you are giving the patient a device, make sure that you set up the device with them. You check and test a transmission. If that works, you also get paid for this time. It's about 15 to $18, depending on your Mac. You get paid to help the patient test their device. Make sure you are cleanly tracking time, whether that be using a third-party technological provider, doing that within your EHR, doing that within ProNex, doing that on paper. Make sure you're very, very cleanly tracking program to program, time to time. I recommend for many people, instead of just doing 10 minutes, right? I did it from 4:30 p.m. to 4:39 p.m. It'll help you in the event of any audit because you clearly have stated time rather than just say, well, I spent 10 minutes on that day. When you submit the claims, now, if you're currently not submitting the insurance and you're doing cash pay only, that's a separate way to do it. But if you're submitting to insurance, making sure you submit the correct place of service, the correct rendering provider, the correct billing provider. The place of service would be where, because this is typically a virtual in-between visit programs, the place of service would be where you typically treat the patient. So if you are a 100% virtual provider, you use the place of service for your normal E&M codes. But if you are an in-office provider versus an in-facility provider, et cetera, you have specific places of service for how you bill your E&M codes. I recommend just copying those. And the rendering versus billing provider, if you are, make sure you're clean. While you may use health coaches or healthcare professionals, or using Maya and Dr. Marcus, you may use Maya, but Dr. Marcus is overseeing the care. Dr. Marcus is a billable provider to the insurance. Dr. Marcus is who shows on the claim. Look at now, as you get payments back, you're inevitably going to get some denials. It's just the nature of the business we're in. Look at the patterns, understand what those denials are. How can you fix those denials on the front end? If you're getting your major denial is eligibility, that typically is because your verification of benefits is wrong. And like I said earlier, you may be contracted with United Healthcare, but you might not be contracted with that one specific plan. Or you may be contracted with United Healthcare, but these codes are not in your contract. So as you get the denials, look at them immediately, because you're treating this patient month over month, and these denials very quickly stack up. As you submit the claim, it takes 30 to 45 days for you to get a response. So you've already submitted the second claim. So as you're at scale, if you submitted 10,000 claims in 1 month, you've submitted, in reality, before you get a response, you'll have submitted 20,000 claims And if you get a large set of denials, you want to work those and figure that out immediately. You do not want to wait. And look at the payer variation. I can't say enough. Look at and do your verification of benefits. Look at your contracts, because it is a CM. These are all CMS programs. CMS covers all of them. Many Medicare Advantage follow. Many, if not all, Medicare Advantage follow suit. But some of the commercial plans, they can decide not to cover it. Some of the Medicaid plans do not cover it throughout the nation. And really, really look at your region and your zip code, like what is covered and not. It's very, very important, because if you don't, you're going to break and get your denials. And then if you skipped one of these steps throughout and you have 20,000 denials, you've provided a lot of care and you have to write off a lot of money. So it's very important that you avoid that by just checking the boxes beforehand.
Sumit,
Yes.
the previous slide where you talk about time and how important it is about claim submission and understanding denial
So,
patterns, and the stacking the stacking slide, right? So is that what a billing software or a company should be helping you with, so that I don't have to write down everything and feel, oh my God, I have to do all this?
yes. So
Okay.
you find the right billing company that understands what these programs are. There are many billing companies. I do a lot of talks on the RCM side of thing. There are many billing companies that haven't done these programs before. And that's okay. They're learning. These are all newer programs, but find a billing company that understands it so they can take a lot of this off your back. For documentation, for time tracking, they cannot help you. That's clinical. Those are clinical requirements, but they can check those before they submit the claim, saying, hey, Deepa, I saw you treated this patient. You said we should be billing this, but where's the
Okay.
time? Why haven't you documented time? I can't bill this. So the billing company can give you that feedback. They cannot do the clinical documentation, but they
Sure.
they can even communicate with patients to get the consent
Okay.
for patients. They can do your contracting. They can do your verification of benefits. They can do all of that for you.
And then Sumit,
Perfect.
do you sorry, it's Carol here, but do you end up integrating some of those into your clean claims process so that before you're submitting it, it can actually be audited ahead of time and caught before it's ever submitted, I assume?
Yeah, so that'll be like each billing company might call it a separate. They have so many terms for it these days. That's why I didn't use the term. But yes, that'll be one of their like pre-submission checks
Okay.
on the program. Okay, did you meet the needs for this? And that's why if you are an independent provider, I recommend having a billing company, because they help you avoid denials. They do that heavy lifting. They are the expert at what they do. You went to school to treat patients. They went to figure out how to get you paid. So
Thank you.
use those experts. So we've talked about all of these so far, but I think one I want to focus on, two is really the middle row of these boxes in compliance. Be very, very clear and be very compliant. Understand any kickback considerations in the partnership structures. I have seen both provider organizations and RPM companies build in like a kickback for the number of patients or for the number of data, which is 100% not allowed. So double check, make sure you are not putting yourself at risk. And that's tied to really the OIG has flagged these areas. The OIG is heavily looking, even part of the Medicare proposed rule that came out this week was about trying to limit some of the usage of third-party RPM companies, hiring them as your staff. You can still use the technology, but using the clinical care in-house as opposed to outsource. It will be interesting to see how that falls when the final rule is released later this year. But Medicare is looking at it. The OIG is looking at it. be very careful. And if you are not documented, do not bill. If you're not sure, your local MAC always has people available to help you. They are very, very helpful if you ask them questions. If you're doing this upfront before starting a program, if you've done it wrong, and they will not help you, they will just take back your money. So it's important to ask and honestly find the right partners to help you. There are many companies that have done this for a very, very long time that can help you figure it out. Whether you use them as consultants or whether it's your billing company, whether it's your technology vendor with like ProNex, whether it's your system, like if you work in a health system, people have done it before. Use them. Use the tools at your fingertips to make sure you're doing it right. These are very, very beneficial when you do it right, but when you do it wrong, the penalties are very, very bad. So it's important to look at all these pieces. Don't cut corners. Don't just jump in like you know. Make sure it's right. Just bringing this back up as we're coming close to the end. We're just gonna repeat some of the slides we've talked about earlier, but these are the various programs. You can stack them. The rates vary, so do not take these rates as gospel. They vary. It will different in your location. It won't be crazy different, but it will vary. These are the pieces I want to keep up and repeat. Be very careful. Think about these. Make sure you get consent. That example I gave earlier about sending my family member home with a piece of paper, that does not qualify for this. The whole point of it is to get rid of having your patients try to document and share information with you. Manual data does not qualify. Make sure that you are very, very clean in your time tracking. Make sure you review your own enrollments, what can and cannot overlap. Get someone to help you with billing so your claim submissions are clean. It's a cash patient. It's a little bit more lenient on your documentation, how you do it, because the patient is a cash patient. The patient is understanding the risks. Still get consent on a cash patient. Review your denials. Review the coverages and your contracts. And make sure, whether it's you or you get your billing company, or even if we're talking Dr. Marcus and Maya, have Maya review Dr. Marcus, have Dr. Marcus review Maya on the documentation on what could be missing for the time. And in all honesty, like I said earlier, you're probably providing these types of care already. Look at your documentation on the same patient. If you've had a patient for 12 months, and see if you're providing any of this. It's honestly a good piece of homework to review a couple patients that you've seen for a long time, because you're probably already providing CCM services or PCM services. You're already providing some form of collaborative care services. You may be outsourcing that, sending them to a dietitian or sending them to a physical therapist, but you're doing that. And there's ways you can bring that in-house and manage that yourself. These importance, why these programs, why they're important. If you do these programs, you are really, really giving that whole person care. You're filling those gaps that are typically there between visits. Historically, from a primary care provider standpoint, you see the patient once a month. Realistically, they don't show up every month. So you probably see them once a quarter or once every 6 months or once a year. And what happens between those check-ins? A lot of times you will miss those early warning signs if there's no way to see what's happening. You cannot treat what you don't know. So these programs are there to help you monitor patients' conditions, coordinate their care, help catch problems early. Be preventative instead of treatment after the fact. And I'm going to go back to that same example because of the paper, because this technology reduces the need for you as a provider to sit in the room and read 60 transmissions on a piece of paper that hopefully the patient wrote them down right. Maybe you can't even read the patient writing, creating all that headache. These devices are auto synced to a program. Software. It's easy to read. It's easy to look at. You also are able to document a little better in patients' charts. So as that you're documenting care better rather than trying to read a paper. You're not scanning that paper into the chart when you're doing that. Historically, you're reading the paper, giving it back to the patient or throwing it away, and hey, then all that data is lost. Then next month when the patient comes back in, you're scrambling saying, oh crap, what were last month's readings? So use the device, use the data. It is very, very beneficial for you. Start with one. Find a billing program that works. Look at your patient population, whether it's a condition, whether it's a set of patients, whether it's, hey, I just want to give RPM. Start with one. As you look at this, like we talked about, look at your patient population, then decide which programs you want. Then write down your delivery model, whether you want to, if you want to stack some programs, you're going to need to find a partner to help with which devices or which technology. You're going to need the right software partner, like ProNex. You're going to need the right food as medicine partner, Plantrician. You're going to need how do you document? Find the right billing partner. Whether you do it in-house, whether your health system does it, whether there's a billing company out there that can help for you. Do this research, do this homework, and then off to the races and help your patients and get paid for all the care you provide. So, as we do the homework, and I know Karol will share some homework as well, but pick a program and look at your blueprints. And Karol, I will hand it back to you. Do you want me to keep this up or?
I think you can go to the
Sure.
next one. Does it have your contact, all
Oh,
of the
yeah.
contact information for everybody? Yeah. I know this went over tonight, but it just highlights how important this really is and how important it is to have the right people in your corner. I know working with a lot of different practices, it's so important to have somebody who understands the billing and collections, like Sumit said, whether it's in-house, but having a billing partner who helps you do things the right way so that you're not always chasing your tail and having any takebacks, all that sort of thing is so important, especially because things are changing all the time so rapidly. I put the homework for tonight in the chat, and we're really honored, as you know, as ProNex is, to be partnering with Plantrician and also to be working with Sumit and Abstract, because these are the people that you want in your pocket. These are the people you want to be helping you to navigate things. So we're actually going to have Sumit back next week. And one of the things I know when you work with a billing company or whether you're doing it in-house, one of the most important things that I work with all the time, no matter who I'm working with, are your metrics. So we talk about marketing metrics, we talk about team metrics, we talk about all these different KPIs, but your metrics related to your billing collections and your whole financial aspect is so important. So we're actually going to come back and really tie this all together again in terms of the metrics that you need to be tracking. And so we're going to do that. We get to have Sumit back next week. Thank you. We're looking forward to that. And we're excited you were here. Thank you for staying. And we do have a lot of people who watch the replay and then send questions in. So you had the contact information, but if you get it to Deepa or I or anyone in Plantrician, we'll make sure that we can get those questions answered.
And then I just have to mention something here, which is, there is a perception out there that there is no money in lifestyle medicine and the reimbursement is not good, which I understand. That's how it was. I started 20 years ago. I had to figure out the billing, the CPT codes, diagnosis codes, everything on my own. I kept the engine going, so I know there is the model can be self-sustaining from business point of view. what is super exciting, like if we go back to Sumit's timeline, is how more and more codes are being recognized and are being added. And now it has come down to health coaches and more codes for dietitians. So this is really going to become a collaborative effort and a workable, financially workable and sustainable model. So I think the fear that, oh my God, I don't want to take insurance, doesn't need to be there. With right processes in place from that one patient case study, moving forward is a way to launch and scale. But I'm looking forward to learning more from Sumit next week. Thank you so much for everyone for your time, Plantrician, Sumit, Karol, and see you next week.
Thank you, everybody. Have a great week.
Bye.
Thank you.